can the state mobilize funds equitably for UHC?
Suggestion we came up with is the government can raise revenues through earmarking, maybe through counties that have natural resources like Turkana. They can use what is gotten by the county governments, the revenue gotten, and it can be taken to the national government to cover for the same. Then the other one was subsidization of healthcare services.
One of the main debates that we had here, a heated debate, was whether earmarking is a good idea or not a good idea in terms of mobilizing resources for universal health coverage. So earmarking is a situation where taxes are collected and set aside for a specific purpose, as opposed to being left, flexible to be distributed to whatever needs in health and out of health. But there are also arguments against it, which is the fact that, so if you earmark for health, and the Minister for Agriculture comes and says, I want to earmark for agriculture, and the Minister for Industry and Livestock and everyone basically say they want to earmark, then what does that mean? How much earmarking can you do, and will there be available resources to do that? So that's the first thing. Secondly, when you earmark, it might actually work against you, because then when the Ministry of Finance is thinking about allocating resources, they'll say the health sector already has these taxes. So let's focus on the other sectors. So it might actually work against the health sector. So one of the ways that was suggested to mobilize resources is to improve efficiencies, to reduce the wastage that happens within the health sector. And the observation that was made, which I completely agree, is that the poor are the ones that bear the greatest brunt of inefficiency or corruption. And so when we tighten these loopholes and when we improve efficiencies, then we are actually mobilizing resources in an equitable way. Thanks.
How the national government should distribute resources equitably. So how should the transfers to counties reflect equitable principle?
We consider the current CRA formula that is based on different variables. We have the issue of population, we have land area, we have equal share, we have issues of poverty, we have development factor and fiscal discipline. Then we asked ourselves, okay, among all these, is there a better method of distribution? We arrived at, it was discussed that poverty and population are interlinked in the distribution of resources. We cannot distribute resources if we don't without considering the issue of how many people are poor at the poverty levels, and what's the general population.
It's good to be able to define the function and ensure that resources then follow the function. Then we need to be very realistic in the criteria that we set. We're also proposing that population needs to be given a higher weight in the criteria. We were also proposing that we need to be able to reduce duplication between the national government and the county government, so that the amount saved can then be reallocated to some of these functions. We then also said that we need to improve accountability. We need to use evidence in the transfer of funds. We need to have more information given as we transfer the funds.
And as the group was sitting in, rightly outlined the parameters that are currently used by CRA in a revenue division to the counties. The interesting thing is that when we outline those parameters like that, then in the discussion, people quickly focus on them and begin to work with them. They don't think from a blank piece of paper. Of the discussion between that number 2 question, how this revenue, and the universal health care question is a good one, intersection, which is going to really exercise the minds of our minds at CRA, and to just see, as we are moving in that direction of universal health care, how does that impact on the way we actually distribute the resources, and is there something that we need to tweak to achieve that objective of universal health care better. Last one, on the various levels, level 5. Mind you, there's legacy issues. Level 5s were previously the provincial hospitals. They were there, and they've always been there. Hence, the fact that they get a little bit more money because of the work to do. But things are quickly changing. Every county is investing, they're getting equipment, and they're upgrading their hospitals to a near level 5, even if not level 5. But the good thing is it's happening. All those levels are improving, and every county is striving hard to improve their level 4 or level 3 to tackle that.
How do we budget for resources equitably within the county?
The first issue that should be considered is data. And also we've looked about the roads and the infrastructure, because maybe you are locating to a certain sub-county or county to maybe hospital, they need a hospital there to be built, but you have to look first. Is this place, is the infrastructure, maybe is it safe? So you see, the money that they are going to be allocated will be different to that hospital way, be mere they just near the highway, the road is just already there. So those are the things that we have to consider for the best equal resource distribution in terms of health.
If we want to achieve UHC, we have to focus on the primary health care. In a county whereby you are putting up, for example, a 4 billion referral facility, do you need a 4 billion referral facility when the primary health facilities don't have the Panadols? And then 3, I've been wondering, do you need the 47 referral facilities in each county? Even in counties whereby the distance from one referral facility to the other is less than 10 kilometers. Do you need like the 2 referral facilities? Then second last, the oversight role of the MCAs. But if you ask the MCA, if you go out for an outreach to do oversight in a facility, what exactly are you going to oversight? They don't know. So that's an area we can build on. And finally, it's about leadership and management, a very key component of UHC. We are to achieve that.
How do we distribute specific inputs equitably? So I'm talking about health workers, how do we ensure people have drugs, and so on. Should we distribute these inputs to ensure that they're where they are needed?
Our group came up with 4 points, and the first point was the national government should distribute the health personnel and specialists in different counties. And then the next point, we saw that we need transparency between county government, national government, and the private sectors. Then the third point was we identify the primary issue in the different counties that you have. And then the last point was to have meaningful public participation on the health budget.
And I agree with your recommendations. I mean, there are 2 things that come out of it. One is that listening to you, giving suggestions about considerations that should be used, reminds me of the fact that, these allocation, it's a priority setting or a resource allocation process, and it needs to have an explicit criteria. Okay? So when we talk about how do you allocate resources across counties, how do you allocate inputs, you have to ask yourself, what considerations are we going to make? And you've given examples. You don't want to give an excess of an input in one place and it's not required, and less input in another place when it's required. So you need data to tell you what are the needs, for example, and so on and so forth. So we need these criteria to be explicit, they need to be known, and they need to be used. And secondly, and most importantly, is you talked about community participation, which to me means essentially, number 1, accountability, making sure that the system is accountable to the final person who is the citizen in the streets and so on. And secondly, it's about making sure that community voice is considered in decision making, because we are making decisions that will affect citizens. So we cannot make decisions that will affect citizens and then we do not incorporate their values and their voice. So priority setting processes have to incorporate very explicit criteria, and they have to make sure that they are grounded on community voice. And this is part of what we are trying to do as a health benefits advisory panel, which is to come up with very explicit criteria for making decisions about what services to cover and what services not to cover, and making sure we have community participation, we have community voice in the process.
Came up with 3 points. Number 1 being, we should set up follow-up committees on policies to ensure that funds follow functions. And these committees should not only be based at the national level, we should even have committees at the grassroots, at the village level. Number 2, we should include everyone, public participation, not only in Nairobi, even at the grassroots, the mamambogas. We should tell them that we have a public participation on this. Then number 3, we should enlighten people on universal health coverage, whereby when we are advertising these things, we should not just put them on Twitter or Facebook. We even advertise them on our local radios on such a thing.
1, communities and civil society organizations, or CBOs, should be involved. And then an oversight body to oversee county governments and work as well as, county governments work as well as the county assemblies. And then the establishment of health data centers. And then lastly, awareness creation.
I would like to say that for accountability purposes, so that at least accountability can be seen, I think the following points as per my group has laid down that we should involve the community, at least community participation, even the mamambogas from the grassroots level, not only from the national level. Another thing is that they should work all along with community health volunteers. If they work with community health volunteers, they will have this good, at least, report to implement anything they want to implement on the ground. And because it has come from the community level, it will be able to favor even the poorest person. Another thing is that they should work along with the chiefs, because you also know also the chiefs, they reach the community easily when implementing any of these things.
We have students from the university, colleges who are 18, and most of these are not covered by their parents. And for me, it's a concern, because as much as I would want to pay that 500 shillings, and I have like 3 or 4 children in colleges, when it comes to 2,000 per month for the NHIF, it becomes very, very difficult. And no one in NHIF answers that. So there are very, very many small things. And for me, I wish this would be a longer period, and then we'd have somebody from NHIF to answer all these many concerns, things that are on their website that are not addressed. So mwananchi actually suffers a lot. And so because of this suffering, we say, wacha nikaa, and then when you get sick now, yes. If
your son is over 21 years, is in a college or a university, but he can prove that he's in school, he's still covered by your insurance. So the only thing you need to do is to prove the person who is over 21 years is still in school.
There's a question around how do you bridge the gap between the community and facilities. And in work that we have done has shown that actually when the further down you go, once you start getting to primary healthcare facilities, once you start getting to community health systems, then service delivery begins to become more equitable. But as you come up the system, when you start focusing on hospitals and level 5 and level 6, then you begin to see resources being allocated to the rich and the poor being left behind. So the simple message is we must prioritize and invest, not just talk about it, and invest in community health systems. So that is an explicit goal of universal health coverage.